Peace. Welcome YouTube to the YouTube live book reading of clinical application of respiratory care. Peace, peace. Welcome. I'm your moderator and narrator, Uriel Riley. So, redo in play. That's what we have to do sometimes, Masters always want to be master. So, after the wonderful meditation yesterday and grocery giveaway, we are in for a replay of the 39th edition of reading Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. So welcome, everyone. Here we go. Episode 39. Again, down at the bottom of page 227 is where we will pick up. IPPB therapy. IPPB therapy has no rationale for the patient who is capable of taking an adequate breath spontaneously. A FVC, force vital capacity, greater than 15 milliliters over kilograms essentially rules out IPPB therapy. In addition, IPPB therapy must deliver at least a tidal volume exceeding 75% of the patient's FVC to be effective. We have previously stated that IPPB must be applied and evaluated on its mechanical effects, i.e., to provide a deep breath, a good peripheral distribution of gas to assist the cough. IPPB is also useful in manipulating the ventilatory pattern to improve ventilation distribution, which in turn may result in re-expansion of atelectic alveoli. IPPB therapy must not be thought of as solely as a means for delivering medications. It's in circumstances involving mucosal decongestion, relieving bronchospasms, and delivering mucolytic agents. IPPB therapy may be adjunctive and beneficial to the overall medical program. Peace, peace. IPPB therapy is almost always used to improve the cough. An example is the patient who has an inadequate inspiratory capacity, less than 12 milliliters over kilograms, because of 1. Pain and decreased vital capacity, and neuromuscular disease. Nervous system and neuromuscular disease, 2. 3. Restrictive and obstructive pulmonary disease. And 4. Abdominal distension and pain, and countless other conditions. Chest physical therapy. In the middle of page 228, for those following along, thank you so much for reading books with us. This is the peaceful part of YouTube where we read books and learn from masters. So now we are closing in on the close of this chapter. Thank you so much for reading with us. Chest physical therapy. Manipulating the chest wall and utilizing gravity as a means of mobilizing secretions are invaluable modalities in promoting bronchial hygiene. The basic techniques of chest physical therapy that aid in bronchial hygiene are postural drainage, chest percussion, and vibration, and cough instruction. And we were detailed this perfectly with Stop and Smile, one of the mods on here. Hi, it's Heart Love. Peace, everyone. Thank you for reading with us. Stop and Smile was giving us this protocol for chest therapy, physical therapy. Thank you so much. That'll be in the replays, and I will put the vocabulary as well in the description under. Postural drainage is used to mobilize secretions that have that the cough mechanism is not adequately mobilizing. Gravity is used to aid the movement of secretions from small peripheral airways toward larger airways. The importance of postural drainage in prophylactic respiratory care is without equal. In our experience, the greatest benefit of chest physical therapy techniques is in the augmentation of aerosol, SMI, and IPPB therapy. Proper aerosol therapy includes coughing instruction and postural drainage. Appropriate SMI and IPPB therapy must include breathing and cough instruction. The application of chest physical therapy techniques without aerosol and IPPB is appropriate in certain disease entities and in chronic home care programs. Patients with copious fluid secretions can accomplish bronchial hygiene with chest physical therapy alone. An example is bronchiectasis, a disease of saccular deformities of bronchi and bronchioles, with the accumulation of secretion within these outpouchings. Postural drainage with percussion and vibration accomplishes mobilization of these secretions into the bronchi, where they can be coughed up. That's how it do it. That's how it works. Peace. Eyes, heart, love. Thank you so much for being here. Oh my goodness. Eyes, heart, love. Yes. That's why we're reading it to the people for free. You know, this is very valuable information, especially to the parent or breast tech or someone inspiring to be in the health field service to help with respiratory care and the MCAT. So thank you so much for being here and reading with us, Charlie. Hi, it's Heart Love. Down at the bottom of page 228. The application of chest physical therapy techniques without aerosol and IPPB is appropriate in certain disease entities and in chronic home care programs. Patients with copious fluid secretions can accomplish bronchial hygiene with chest physical therapy alone. An example of bronchiectasis, a disease of saccular deformities of bronchi and bronchioles with the accumulation of secretions within these outpouchings. Postural drainage and with percussion and vibration accomplishes mobilization of these secretions into the bronchi where they can be coughed up. Cystic fibrosis is another disease where chronic long-term bronchial hygiene is well accomplished by physical, chest physical or therapy modalities. However, aerosol therapy is most helpful in these patients, especially when they have acute disease superimposed on their chronic states. Peace. Welcome, YouTube. We're pushing towards 1,000. Yes, we're pushing towards 1,000 subs on this part of YouTube where it's peaceful. Read books and learn from masters. So I honor all the book readers and writers, the book lovers community. We're part of Highest Heart Love. Thank you so much. All right, here we go. Aerosol IPPB therapy. Top of page 229. Modern respiratory care has shown that where individual modalities of bronchial hygiene may not be therapeutically effective, an appropriate combination of techniques may be extremely effective. Since a great number of patients receiving bronchial hygiene therapy have dried, retained secretions, and mechanical difficulties in distributing ventilation, it is not unusual to find a high incidence of intensive care patients needing both aerosol and IPPB. There is a great debate about whether the aerosol should precede or come after the IPPB, or whether the aerosol should be given simultaneously. The answer becomes obvious when care is taken to evaluate the patient and define the goals. All right, so this is important if you guys are taking notes. Here, you want to jot these down, okay? In the middle of page 229. 1. Aerosol therapy followed by IPPB therapy seems to be the most widely used combination. The objective is to first provide proper aerosol therapy to maximally hydrate secretions and then administer the IPPB for effective coughing and appropriate medication delivery. In our experience, this has proved to be the most effective method of giving the combined therapy. 2. Many respiratory specialists prefer to have the IPPB therapy given first, the object being to deliver a bronchodilator to make optimal and distribution of the following aerosol therapy. We feel that the administering of a bronchodilating drug should not be inexorably attached to the IPPB therapy. Inhalation of bronchodilating drugs can be given by cartridge, spray, or the drug can be given systemically. Documentation concerning the effectiveness of these methods is not available. We can only emphasize that the order should be used that best fits the patient, therapist, and physician. You know, you have to always go what's best for the people first, right? And the patients. It's always important for patient care. That's why we uplift the people. We speak life into on this channel, this peaceful part of YouTube where we read books and learn from masters. And I'm a master fitness trainer by trade, train athletes all over the world. I'm at the highest level. So that's why I have the vocabulary to be able to express this information. And I think it's so important that we can give care to one another, that we have the great empathy that allows us to love on one another and create space for those to grow, right? So that's why you'll always see the kind light workers at work here on this page. You will never see anything mean or mean spirited or anything that will pull people down because we're light workers. The light workers, we lift everyone up. We love on one another, right? Thank you so much for being here. That's what my daughter learns from. She learns how we treat others, and the children see how you treat others. When they see me on here reading high level books with high level vocabulary and information, they say, wow, one day I want to do that. I want to help the people. I want to heal the people. So that's what this channel is for. Highest Heart Love. Thank you so much for being inspired to be a light worker. 3. Inline ultrasonic with IPPB is a very popular mode of therapy. The rationale is to get better delivery of the aerosol particles by using positive pressure. This is popular among respiratory therapists since it is possible to deliver both treatments in a shorter period of time. It is it has been our experience that there is a higher incidence of increased airway resistance and paroxysms of coughing with inline ultrasonic with IPPB. This method is felt to be an extremely effective mode of therapy when aerosol therapy is indicated, but the patient is unable to provide a reasonable ventilatory pattern for effective penetration and deposition. When delivering inline aerosol therapy, it is incumbent upon the therapist to carefully monitor the patient and discontinue the treatment if there are any signs of respiratory distress or increased airway resistance. All right, top of page 230, aerosol chest physical therapy. Aerosol therapy in combinations with chest physical therapy is often used for patients with retained secretions who have good mechanical ability to cough. The combination of aerosol and chest physical therapy is often used when very aggressive bronchial hygiene therapy is indicated. The treatment is usually given with the patient first receiving the aerosol therapy and breathing instruction, followed by postural drainage and percussion and vibration. See, that's how you do it. That's what Stop and Smile was just telling us in the other live. This is a redo of the last one. Thank you so much for being here in Highest Heart Love. Masters are going to be mastering, right? That's what we do. If we get something a little bit off, we'll do it again. You know, that's what being masters is about. Masters are not lazy. We work. We do the work. We do the work for generations, right? So uplift the people. Highest Heart Love. Middle of page 230. Evaluation of the effectiveness. Thank you for the likes and subs. We're pushing towards 1,000 on this peaceful channel where we read books and for masters. So thank you so much. Evaluation of the effectiveness. The effectiveness of a therapeutic program is evaluated by the degree to which the goals of the program are accomplished. In other words, the effectiveness of bronchial hygiene therapy must be evaluated solely by whether or not the goals were accomplished. This means that the success of prophylactic bronchial hygiene therapy is based upon the prevention of pulmonary complication. With therapeutic programs such as the treatment of atelectasis, the effectiveness is judged on whether or not the atelectasis is resolved. It is obvious why the effectiveness of bronchial hygiene therapy is difficult to evaluate. It can be postulated that only a portion of the patients receiving prophylactic respiratory care would develop pulmonary complications if no respiratory care were applied. Therefore, We are always dealing with an unknown factor that provides uncertainty for the believer and ammunition for the non believer. There are some objective criteria that can be used for the evaluation of effectiveness of bronchial hygiene therapy, and these are: 1. The sputum; 2. Auscultation; 3. Work of breathing; 4. Blood gas measurement; and 5. Pulmonary function studies. Here we go into the ending part of this chapter, down at the bottom of page 230. Sputum. It is not unusual for sputum production to be delayed as much as 48 hours after the onset of bronchial hygiene therapy. The evaluation of sputum production must be on a 24-hour basis. Careful examination of sputum will reveal significant information concerning the disease state present and will document changes in that disease state. Sputum must be examined both grossly and microscopically. The gross examination is primarily for consistency and color. The normal consistency of sputum is a watery like fluid with little tendency to stick to things. Very tenacious mucus usually represents dehydration. Mhm. Retained secretions have small solid green or yellow flecks, which may represent cast of bronchioles. Color is very important in studying sputum. Sputum is normally white and translucent, allows light to come through, but does not allow you to see through. Yellow denotes pus, since white blood cells have a yellow color. Green usually means old, retained secretions, since proteolysis of mucopolysaccharides results in a green color. When the sputum is green and has a foul odor, it usually means a pseudomonas infection. A brown color usually denotes old blood. Red sputum denotes fresh blood, and racemic epinephrine may turn sputum pink. When sputum contains blood or hemoptysis, it is important to note whether blood is well mixed with the sputum or whether the sputum is streaked with blood. Blood streaked sputum usually denotes tracheal or upper airway bleeding. Remember, sputum contains pharyngeal and nasal discharge as well as lower airway mucus. Microscopic examination reveals the presence of white blood cells. These denote inflammation or infection. Bacteria are always seen on properly strained sputum smears. Only intracellular within white blood cell bacteria are significant since they denote that infection is present, i.e., the bacteria have been ingested by the white blood cells. Peace, YouTube. Thank you so much. Oh my goodness, I love you too, Curso. Thank you so much. We are going to sing it at the end too. Thank you so much for likes and subs. We're almost at the end of this reading, so we will be singing I Love You. Auscultation. Physical examination of the chest often reveals objective evidence of respiratory therapy effectiveness. The appearance of breath sounds, where there were none previously, means that previously collapsed lung is aerating. The absence of improvement in bronchi and wheezes following therapy is a significant finding. Work of breathing. The work of breathing may be significantly decreased when retained secretions are mobilized. That's right, right? We want to ding. That's what we have to connect the dots. That's what we're here for. When the secretions are mobilized, right? They're going to be running through. This may be clinically evident after several days by reevaluating the ventilatory pattern and the use of accessory ventilatory muscles. Of course, one must realize that many other things are being done to and for the patient during the same period, and improvement may be due entirely or partly to these other regimens. Blood gas measurement, page 232. Blood gas measurements may or may not be helpful in the evaluation of respiratory care modalities, since blood gas measurement reflect the total cardiopulmonary system rather than the pulmonary system in particular. Certainly, improvement in the blood gas state following therapy is reflective or effective therapy, but the lack of improvement in blood gases does not necessarily mean that the therapy was not useful or effective. Pulmonary function studies. Pulmonary function studies have long been applied as the objective assessment of the effectiveness of respiratory therapy modalities. However, it is well documented that even significant mobilization of secretions and clinical improvement may not be accompanied by improvement in pulmonary function studies. Summary. Thank you so much for reading with us, High's Heart Love. Summary. Yes, we did it. Chapter 14 is coming to a conclusion, guys. Here we are. Thank you so much. Summary. In the middle of page 232 of clinical application of respiratory care. The formation and evaluation of bronchial hygiene program is one of the prime areas of respiratory care that requires the therapist's knowledge and expertise. Nothing is quite as satisfying to the respiratory care practitioner as successfully contributing to the total scope of medical treatment. We have completed chapter 14. Woo, look, and next we will be going into section 4, airway care. So when we reconvene, it will be the artificial airway, chapter 15, page 235. Thank you so much for reading with us. Clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Highest Heart Love medical books for the people, live from the light here in LA. Peaceful part of YouTube where we read books and learn from masters. Super high level vocabulary. I will put the vocabulary in the description. Thank you so much for reading with us. Thank you for breathing with us. Happy Thursday. We had a wonderful grocery giveaway yesterday. It was here at South LA Cafe. It was 296 weeks of giving away beautiful, healthy groceries to the people here in South LA Cafe. We love you so much. You know, that's why we do this. And this is a service. I don't get paid for this. You know, I don't get anything from it, but giving the people information and wisdom and knowledge. Knowledge of self. When we master ourselves, we can heal ourselves. When we can heal ourselves, we can help others heal. That's what the light workers do. So highest heart, love, and honor. Thank you so much for reading with us. Some love, Ward. Thank you so much. We're pushing towards 1,000 subs, reading books here in this part of YouTube. So we're gonna have some love water. Cheers to all the people. We love you. All the light workers, all the book love community. Highest heart, love. Let's say you have a drink of love water. Wow. I love you. I love you. I love you. I love you. Shout out to all the September babies, all the September solar returns. We're coming up on the 21st soon, right? It's going to be major. I love you so much. All right. Thank you so much. Peace, peace. Yes. Only the, super high, elevated. Yeah, the healers. That's right. We love you. We do. So we want to always be grateful and thankful for all we have now and all that is coming to us. Thank you. I'm ready to receive. I believe I deserve it. Hands open so you can receive, right? Know that you deserve it. Know that you are part of the divine oneness of love. Highest heart love. I love you. I love you. Peace, peace. I love you, Bubbles. Highest heart love. Love to all the light workers, all the book lovers and readers. We will see you soon when we reconvene. We're going into chapter 15. We did it! Completed another chapter. Peace, peace. I'll see you soon. Highest heart love.